This afternoon I'm going to give you an update on Freelite, which is our established test, first released globally in 2001, and I'd like to then move on to discuss our new heavy light chain immunoassay called Hevylite and present you with some unpublished data. Some of that will reflect what was discussed in ASH 2011 at San Diego last December. Throughout all of this, you will hear me mention the clinical applications for these two assays in multiple myeloma. So without further ado then, let me introduce what I will include in the first part of this talk when I will focus on Freelite. First of all, I will mention screening for monoclonal gammopathies. This has been quite topical for the past 2 years now, especially in looking at the replacement of urine Bence-Jones protein tests at diagnosis, this being the seminal work of Jerry Katzman in 2009 in his clinical chemistry manuscript, which we have with us this afternoon. I would also like to mention another paper which was published by Dr. Stephen Holding from Hull Royal Infirmary. This is a district general hospital in the UK that was published last year, and I'm going to mention that in this part of the talk, together with a new area of expertise for us in working alongside our renal physician colleagues. And this is a paper by Professor Cockwell from Queen Elizabeth Hospital in Birmingham, who is looking at acute kidney injury and an algorithm for screening using Freelite. This was published in 2010. Then I will talk about MGUS prognosis, specifically the risk stratification and 2010 MGUS guidelines as published by the doyen of hematology, Professor Robert Kyle from the Mayo Clinic. And then I will finish just by showing you one latest example of how it can be utilized in monitoring multiple myeloma. This was in a small cohort of light chain multiple myeloma cases and presented at ASH last December by Professor Hervé Abeloiseau from the French myeloma working group. Okay, so without further ado then, and by way of quick revision, I know some of you here are from the laboratory, not necessarily practicing hematologists, so just to review monoclonal gammopathies, here we have our plasma cell, which is capable of producing intact immunoglobulin as well as free light chains. And these can exist as kappa, predominantly monomers, also lambda free light chain dimers, and these can give rise to, when cell development is aberrant, a range of monoclonal gammopathies, of which we have this umbrella term for multiple myeloma. It is itself divided into 3 main groups: the intact immunoglobulin multiple myelomas, shown by the Y-shaped intact immunoglobulin molecule, but you will notice they also have a spectrum of production of serum free light chain, alongside the light chain only multiple myelomas representing 15 to 20%, and then the non-secretory so-called multiple myelomas, which produce free light chain but at very low levels. Alongside this, but separate to it, and I'm sorry they've gone across the edge of the slide here, we have those diseases where light chain deposits or aggregates in tissues, and this leads to the development of either AL amyloidosis or light chain deposition disease. A precursor condition, so-called, from which all of these may originate is MGUS, an asymptomatic phenomena for our hematologists, and we will mention that in relation to prognosis later on this afternoon. So it's over 150 years now since Professor Henry Bence-Jones boiled urine to discover that there was a phenomenon within this particular material that might help us diagnose some patients. Characteristically, monoclonal intact immunoglobulin exists in grams per litre concentrations, and we use serum protein electrophoresis to establish this. Secondary to this, we also have monoclonal free light chain, this time witnessed in a serum, certainly at milligrams per litre concentration, as shown by this cartoon. And classically, with the era of Professor Bence-Jones, we have looked at this by urine electrophoresis. And now, as I hope to explain to you over the next 40 minutes or so, you have an alternative which may help you in some difficult cases. Let's look at Jerry Katzman's screening paper then from 2009, where in clinical chemistry he examined 1,877 newly diagnosed B-cell dyscrasias within 30 days of initial diagnosis. And here are the differing disorders that they'd seen at the Mayo Clinic. And as you run your eye down this list of occurrences, I dare say that will look somewhat different to what you experience in your own hematology clinics here in Poland. This, of course, is a tertiary referral centre in the United States, and your own experiences of these disorders may be somewhat different. We will, however, for this afternoon, just focus on the first four and see what effect we have of looking at these with all of the laboratory tests available to us. So what Jerry Katzman and his team did, he said, well, can I replace any of the urine tests by using Freelite? And he took initially a screening algorithm of all of the 5 laboratory tests that were available to him and his team at that time point. So a serum protein electrophoresis alongside serum immunofixation, a urine protein electrophoresis, urine immunofixation, and a serum Freelite. And he said, okay, well, of these 4 disorders, if I use all of those 5 tests together, how many of my patients can I diagnose? And you can see they can successfully diagnose all of the multiple myeloma and all of the Waldenstrom's macroglobulinemia patients, but there is a shortfall for both AL amyloidosis and light chain deposition disease. And I think this highlights something very important, which we were actually discussing this morning, which is today, even with everything that is available in the laboratory, you still need to have that dialogue between the clinicians and the laboratorians in order to achieve a diagnosis in 100% of such cases. Now, that is the Mayo Clinic and perhaps not the real world. What we often find people are doing as a simple screen, and this is very classic for district general hospitals in the UK, is just a serum protein electrophoresis alone, with a possible reflex to a serum IFE if there is an abnormality observed. And you'll see that compared with doing all these 5 tests alone, you get a negative screen in this number of individuals across these differing disorders. So not so good as is seen in the initial case. In some hospitals, they are able to perform a serum test alongside a urine test. And you will see that compared with doing just a serum test alone, an SPE, these numbers do indeed increase, such that the number of multiple myeloma cases missed decreases from 58 to 6 and from 187 to 23, but there is still a shortfall. And this brings us on to another observation, which I will refer to in the Holding paper, and that is that sometimes in these elderly, frail patients, obtaining a 24-hour urine collection is somewhat difficult. And I will show you some compliance data for that shortly to illustrate that that is a real problem for us in 2012. So Jerry Katzman's group then proposed, well, let's just start with an initial diagnostic screen that only looks at serum. And here was their proposal. If you did first a serum protein electrophoresis and an upfront serum free light chain assay, and if either this was abnormal or this was abnormal, reflexed to a serum immunofixation test, you will see that you can successfully diagnose 100% of the multiple myeloma and Waldenstrom's macroglobulinemia individuals. And compared with doing this urine and serum free light chain, urine and serum testing, you reduce the number of AL amyloidosis cases missed initially from 23 to 11. There's another very positive benefit for this for your patients, and that is if you've performed this initially and this, and neither of these are abnormal, you can be pretty confident that you can exclude a diagnosis of multiple myeloma. And that in itself is quite useful when you are reviewing a patient in an outpatient clinic, for example. So let's ask ourselves the question, does screening with Freelite have any additional value? And we will look at this in the context of a screening algorithm of a typical general hospital. So not a university setup, a typical very busy workaday hospital. And here's an example of what's been looked at recently in the UK. Those individual hospitals who perform either an SPE or CZE, one or the other, depending on which technique they're set up for, and a urine assessment, versus those who are performing SPE or CZE and Freelite. And these are the observations of these two studies. There was one performed by Hill et al. In Clinical Chemistry 2006. That's been quite well characterized now for over 5-6 years. And they noticed that detection increased by 12%. We now have this paper, which was published last year in Clinical Chemistry Lab Medicine by Stephen Holding and colleagues, who said that they can see that detection has increased by 7% in their individuals. Now, that compares slightly differently from a certain other study performed which looked at SPE and CZE itself versus those two techniques and Freelite. And this is data that's been reported for some while now. And you can see that here the detection levels are quite striking. Again, Bakshi et al. Reported in Amj Clinical Path that detection was raised by 41% and Robson et al. By 71%. These are well established now. If we look in more detail at the Hull screening study published last year, this is what they did. They took over a 15-month period, 753 samples received for any query monoclonal gammopathy screen. And they found that overall, their Freelite chain assays detected 5 additional patients who were negative by SPE or CZE. 2 of those were multiple myeloma cases and 3 were MGUS. They then compared, well, okay, of these 5 patients who we've detected some abnormality with serum, how many of those did we also receive a urine sample for? And the answer was they received 3, and they came 2, 30, and 49 days after the serum. And this raised a very important concept, certainly in the minds of the UK Pathology Benchmarking Service, who did a study to see how often was it they received a urine sample at the same time as a serum sample. And the result was striking. It was 17%, 17, so really quite low, which is mentioned on the bottom of this slide here. Okay, changing tack slightly, I'd like to mention a new area of expertise for serum Freelite chain, and that is in the area of acute kidney injury, or AKI. And this is of particular interest to our nephrology colleagues who are investigating a screening algorithm when a patient presents with kidney injury. And this is what has been published recently by the professor at Birmingham, who for every patient now who comes to casualty or is admitted to the renal ward at the Queen Elizabeth Hospital in Birmingham with an unexplained acute kidney injury, all of them are screened by a serum Freelite chain. And 2 possible things can happen here. Either there is evidence of a clonal Freelite chain level greater than 500 milligrams per litre, in which case the renal doctors now think, okay, that is a probable karst nephropathy, and that individual then goes on to be worked up for either a renal biopsy or referral for hematology and oncology workup. So that's a new phenomenon, just from the initial serum screen when that patient walks through the door. That's new. Okay, the alternative scenario is that that clonal Freelite chain level is less than 500 milligrams per litre. This is the cutoff they are using, in which case they can be pretty confident they don't have any karst nephropathy. Therefore, they would consider doing a renal biopsy and the hematology-oncology workup, because there may be some other local cause within the kidney that is responsible for this, but isn't due to the association of Freelite chain in the distal convoluted tubule. So some other cause, maybe AL amyloidosis. Over on the right-hand side, you can see you get a very quick indication, if there is a normal Freelite chain ratio in these individuals, that monoclonal pathology is unlikely. And that's really important, because of all the people who come in through a kidney ward, 10 to 20% of those will have an undiagnosed multiple myeloma. And quite a large proportion of those will go on to need kidney dialysis if untreated. And the key facet of renal damage in these individuals caused by nephrotoxic light chain is, if you catch it early enough, you can reverse it with good chemotherapy and use of hemodialysis to remove light chain. So you have the potential to remove somebody from their need to be on dialysis lifelong. So that's a current clinical trial we are performing in the EU known as Hevylite, which I won't discuss in more detail today. Moving on to the MGUS prognosis story then, risk stratification and the 2010 guidelines. If you look at all of these various disorders here, some of which, well, all of which I hope are familiar to you, the answer for free light chain is that it's prognostic in all of the plasma cell dyscrasias that have been examined to date. And I will just focus on MGUS progression today because for our hematology colleagues, this is an enormous workload of patients who are examined regularly in the outpatient clinic. And if we go on to the next slide, this is the MGUS risk stratification model, which incorporates 3 factors: M protein size, whether above or below 15 grams per litre, its type, whether they're IgG or not, and the free light chain ratio, normal or not. And this was a three-tier risk stratification developed by Vincent Rajkumar from the Mayo Clinic and published in Blood in 2005. If we look at how these patients with MGUS vary, you can start with those individuals who are at low risk of progression. They have no abnormal risk factors. So this is normal, and so is this. You'll see that this is a large proportion of patients, about 450, and their absolute risk of progression at 20 years is just 2%. Accounting for death as a competing risk. That's in sharp contrast to if you have one risk factor, again a large number of individuals, but your risk has now jumped to 10%. If you have 2 risk factors, the number of individuals has dropped by half, but your risk is still elevated to 18%. And regrettably, if you are in the high risk category, for all 3 of these risk factors, this one, and this one, it will be only a small proportion of your overall cohort, but the risk now is out at 27%, so almost a third, and dramatically different compared with those who have no risk factors. So clearly, in terms of how you are managing these patients, you will want to be doing something different with these compared with these. And that is reflected in the 2010 guidelines as published by Bob Kyle, where he proposes that those who are at low risk of progression, i.e. those with none of these abnormal risk factors, are seen initially at 6 months by the hematologists and then discharged back to their primary care physician. And what this translates to, certainly in the UK, is that these individuals are now being seen once in the district general hospital and then referred back to their general practitioner, who will monitor them every couple of years, or if they progress to become symptomatic, in which case they can be re-referred to the hospital. That's entirely different to those individuals who have 1, 2 or 3 risk factors who continue to be seen by the hematologists 6 monthly and then on an annual basis. But this group of people, which you remember from the risk stratification model is a large number of patients, are now being referred back out into primary care. If we look at how we can monitor patients then following treatment, which patients can we look at following their treatment? Well, if you remember the diagram I showed you right at the beginning, the answer is you can actually look at all of them that produce light chains, be it a small amount, a larger amount as in the light chain only, and those who are depositing as aggregates. You can, of course, also look at the intact immunoglobulin multiple myelomas, because 89% of those also have a spectrum of production of light chain, which you can detect with the assay. That's the work of Graham Mead in the British Journal of Hematology in 2004. Just like to finish the Freelite part of this talk by illustrating this data from Hervé Avé-Loiseau, published in Hematologica as an abstract and presented at ASH at the end of last year, where he's looked at a cohort of light chain multiple myeloma patients looking at the ratio shown here in logarithmic scale on the y-axis versus how they performed, looking at urine testing as they went through cycles of chemotherapy and a stem cell transplant. And if we look at this one individual, you'll see that they were urine immunofixation positive only at the initial time point when the capital lambda ratio was itself way abnormal. And as they instigated treatment, shown here at cycle 2, cycle 4, and after the autologous stem cell transplant, you'll see that they became urine immunofixation negative very quickly. So we've only got one position at initial diagnosis where the urine tests were positive. If we contrast that with what the serum free light chain test was showing, yes, they showed a highly abnormal ratio at initial diagnosis indicative of monoclonality, and that has indeed come down, but you'll notice here with the blue interrupted lines, as they started the cycles of chemotherapy, it didn't enter into the normal range. So it was only after this individual had had the autologous stem cell transplant that from a hematological point of view, they have a complete response. Until that time point, they are still responding to therapy. So we are getting different information from the different tests. Okay, I'm just going to summarize Freelite for the first part of this talk then. I would like to suggest to you that serum free light chain assays can indeed replace urine testing in the initial diagnosis of monoclonal gammopathies. I hope I've shown you some preliminary evidence that serum free light chains can improve screening of acute kidney injury. And moreover, that the ratio itself is an independent risk factor for MGUS progression to malignant disease and can help you stratify out your patients. The free light chain assays can assist with management for two reasons. They can rapidly indicate response to treatment, and not shown today, they allow you to detect the phenomenon of light chain escape, which is relapse in intact immunoglobulin multiple myeloma patients. I'm now going to change tack slightly and talk about our second flagship assay, which is the Hevylite assay, and show you some recent data to support our very optimistic view of what this assay can do. So the focus of this part of the talk is to give you an overview of our Hevylite chain analysis and its potential benefits, and show you the published and unpublished clinical data in two main arenas really, monitoring and also in prognosis. So this familiar slide, we talked about monoclonal free light chains in the first part of the talk, and at that point I said, well, we have serum electrophoresis to look at these. I'm now going to tell you that we have an alternative. We have a serum heavy light chain test, which may also help us. So if we focus on this, why should this be relevant to us? If we look at the International Myeloma Working Group guidelines, this is what they have to say about multiple myeloma follow-up. For patients who have a measurable monoclonal protein in serum, you should look at both electrophoretic studies and quantitative immunoglobulins. These are both recommended to assess a response, although the electrophoretic methods are preferred. Now that's fine as far as it goes. However, I'm sure everybody here would agree, sometimes there are some issues with electrophoresis. Some of these results can be difficult to interpret, and I've given some indications of why that might be the case here. You might see broad bands or smearing of bands. Couplets and triplets are possible. You might get precipitation of immunoglobulin at the site of application, so you're not running the entire sample out under the electric charge. Sometimes you see some dye saturation effects, or there may indeed be some hidden bands. This is known to be a particular phenomenon with IgA, and this particular issue was one of the reasons why we decided to look at Hevylite. This was a particular concern of our biochemists in the UK, and they said, well, okay, we've got this issue. Some of the IgA bands can be hidden by transferrin. We spend a lot of time with lots of people in the lab looking at these particular cases to see if we can decipher them. And so I'd like to show you this group, which we've looked at in-house. So here is a normal healthy serum, and I've itemized the bands here on the left, alongside 18 separate different IgA multiple myeloma sera. And as you can see, they vary quite significantly as we go from left to right. I could focus on the three on the right here. I'm sorry, they're just on the edge of the screen. And I think you would agree that where there is an M protein band here, that's sitting pretty much in the beta-1 region for transferrin. Where do you draw the line from where your transferrin band finishes and your M protein band starts? So if we look at what these consensus guidelines recommend, they say for several patients, specifically the IgA is quite common, the IgD is quite rare, nephelometric quantification of the serum immunoglobulin is necessary. Yes, I agree, it most certainly is. However, with a standard nephelometric IgG, IgA or IgM assay, you have one phenomenon that may not give you much information, and that is the measurements do not distinguish monoclonal from polyclonal proteins within any given sample. Let me illustrate what I mean. If you measure total IgA, you are by definition measuring IgA kappa, that form of the light chain attached to the heavy chain, and IgA lambda. And in a multiple myeloma patient, one of these will be the involved immunoglobulin, i.e. the one producing the tumour. The other one will be the uninvolved immunoglobulin, forming the background polyclonal immune response. Let's think about what that means in terms of Hevylite as a reagent. This is what it looks like. So here we have two heavy chains with their associated light chain, and our Hevylite reagent has been developed taking a slice here across the junctional epitopes between the heavy and the light chain. So that's what they look like in cross-section. Like our serum Freelite chain assay, they've been developed using polyclonal sheep antiserose reagents, and they are specific for these junctional epitopes that span the immunoglobulin light and heavy chain. What does this mean then? It means that we will be able to separately measure the IgA kappa component and the IgA lambda component. And so for ease of recognition, I've coloured these in separate shades of green. These are the Hevylite specificities that exist today to be looked at across multiple myeloma patients. So there are 6 of them in pairs. So IgG kappa, IgG lambda, the same for IgA, kappa and lambda, and IgM, kappa and lambda also. Much as you are used to utilising for the Freelite assay with its associated ratio, we have also derived ratios for each of these classes of intact immunoglobulin. And their normal ranges are shown at the bottom here. Whoops, that was a bit too fast. So what additional information can this give you over and above what you have today? Well, this is what you can do. You can get an appreciation of this involved immunoglobulin, let's say it's this one, the IgA kappa component, as opposed to the uninvolved immunoglobulin. And this is what would happen in a patient sample. You have a tumour, so the IgA kappa is the clone pumping out aberrant cells. And in contrast, look what's happened to the IgA lambda. This has been diminished. Immunopoiesis, a well-characterized observation in multiple myeloma cases. What you can now do is see the size of that, because we can get a quantitative measure of this and a quantitative measure of that, thereby seeing if there is any, what we term, heavy light chain pair suppression. So this tumor is suppressing the alternate chain. So, there is another second advantage to looking at Hevylite, and this is because it's helpful in correcting for variable immunoglobulin G metabolism. What does that mean? If we look at the half-lives that are quoted characteristically for the immunoglobulins, IgA and IgM, you see, are similar, 5 or 6 days. Whereas IgG, we know, is much longer than that. It's about 20 days to weeks. The question is, why is that? And perhaps this particular receptor will be familiar to you. It's the FcRn, or neonatal Fc receptor, which ensures maternal transmission of IgG from mother to child. But it doesn't just work in that scenario. It also recycles IgG to prevent the excessive loss of this particular molecule under normal circumstances. And what do I mean by that? Let's look at quite an old paper which illustrated this phenomenon from Waldman and Strober in 1969, where they've done 2 things. They've said, let's look at the immunoglobulin G half-life in days versus the serum IgG concentration. And when the serum IgG concentration is low, you'll see that that half-life is quite a long time, extended out to almost 50 days. The converse is true when the level of serum IgG is high. Now, when might the serum IgG level be high? When you have production of a tumour, and you will see that this serum half-life is reduced dramatically to only about 10 days. The reason for that is you have saturated the neonatal Fc receptor. What that means is your IgG M protein production is probably being underestimated. Hevylite, because it's giving you a measure of both the involved and the uninvolved chain, corrects for that and these effects of variable metabolism. So you just have a better handle on what's happening specifically in the IgG group. Let me show you a cohort of around 210 patients from the French myeloma group who looked at IgA Hevylite chain at presentation. And similar to the dot plots that you will have seen for Freelite chain, we also plot the similar fashion for Hevylite, this time IgA kappa on the x-axis and IgA lambda in grams per litre on the y-axis. We have our area of normal individuals in the center here within these two tram lines that separate polyclonal from monoclonal disease. And you can see that it successfully separates out those individuals with the blue squares who have an IgA kappa IgA myeloma from those who have an IgA lambda. I'd like to draw your attention to the three areas numbered 1, 2 and 3. These three we couldn't detect any band by SPE, but what we have been able to show is monoclonality using a Hevylite methodology. So it's giving you some additional information in IgA. If we look at IgG, the pattern is similar. This time looking at a slightly smaller subset of 112 individuals, and you can see here it successfully delineates those individuals who have monoclonality from the polyclonal normal population. Okay, so what does that mean for you if you wish to use Hevylite in normal routine practice? We suggest that the best place to start utilising it is in monitoring your multiple myeloma cases. And this is why. In Clinical Chemistry in December, this paper, a case report, was published by Leslie Donato and his colleagues from the Mayo Clinic, where they looked at this lady, a 71-year-old woman who had multiple myeloma after a stem cell transplant. And these were the phenomena that they observed with this lady. She had a clinical history of 9 years of MGUS, and at the time they saw her in 2006, she presented with anemia and hypercalcemia. She had an SPE done at this particular time, shown over here, January 2006, with an associated IFE. And you'll see that her SPE showed 48 grams per litre of M protein. There's the M spike. I can't really miss that one. And IFE, a monoclonal IgA kappa. There's the A and there's the kappa. So far, so good. She was found to have a raised total IgA level, 47.2 grams per litre. That's good. That's correlating pretty well with what we see here. That's looking very, very helpful for our particular doctors. She also had, because this was done retrospectively, a Freelite chain test at that time, which said, yep, definitely monoclonal disease. We've got a kappa to lambda ratio of 7. So as you might expect, she then went on to be staged with her bone marrow biopsy. That showed 40% plasma cells. And so she was diagnosed, as you might expect, now with multiple myeloma, Jury-Salmon stage 3A or international stage 2. She had treatment and monitoring, which included a stem cell transplant, and she became asymptomatic. And her electrophoresis patterns were negative for 1.5 years. Here we are in August 2006 after that initial treatment, and you can see that M spikes disappeared, as has the abnormalities on her IFE gel, so she's gone into remission after the stem cell transplant. Regrettably, that was not sustained for very long. She had a first relapse 2 years following the autologous stem cell transplant, and at this time point, this is what they looked at in terms of her laboratory investigations. And I will show here over 10 time points that she was analysed using the reference intervals for each of these tests, what the total IgA showed, what the immunofixation assay showed, what the Freelite chain ratio that was looked at the same time illustrated, and how that was different to what the Hevylite IgA kappa to lambda ratio was telling us. Over on the right side are the things that were being changed by the clinician in response to her disease. So here is where the IgA levels are coming out of the normal range at time point 3. You will see that alongside that, the time points when the IFE actually becomes positive are right down here at point 9 and 10. That observation was also observed when looking at the Freelite chain ratio. But if you look at this one over here on the right, that's an entirely different scenario, because these abnormalities are actually there from the time that she first presented. So this assay is giving you different information to what are these two, and indeed what is happening with the IgA. Let me now show you what that looks like if you plot this in graphical form. And this is something we're developing a standardization for at the moment. What I want to show you is this lady's monitoring over 3 years, so from January 2008 to January 2011, from the time of initial relapse. And on the left-hand axis, I have plotted the Freelite chain ratio. On the right-hand axis, how IgA, total IgA level, over with time in days on the x-axis. So you'll see here, she has an electrophoresis, which is positive. This is her M protein, and then disappeared as the IgA level comes down to within normal range. A similar thing was happening to the Freelite. It just took longer to enter into the normal range. I want to illustrate what happened to her at 2 key time points. Around about here, as her total IgA level started to increase, clinically they suspected a lung infection. Interestingly, the Freelite chain ratio here is normal, so that's not giving you any indication that there is any monoclonal disease. However, they'd also looked at Hevylite in this lady. And let's look at how that looks different to what the Freelite chain and total IgA are telling you. This is initially high, and it drops down, much as does the Freelite chain ratio. But whilst the Freelite chain ratio normalizes, you'll see that the Hevylite chain ratio never does, implying that there is still some minimal residual disease in this individual. Now, at the time that she was suspected to have a lung infection, let's have a look at what's happening to these particular values. The IgA is going up, implying some ongoing immune response. The Hevylite ratio is absolutely stable. So what that's saying is whatever's happening in the tumour is exactly the same as what's happening in the polyclonal uninvolved chain. The Freelite ratio is starting to come up, but it hasn't gone above the normal upper range. So this is telling you something different here from the IgA measurement. That then changes as we move further along, and this individual was treated for her lung infection and the IgA level stabilizes, but the Hevylite ratio is starting to elevate. So whatever is causing that in terms of her underlying disease, because this has never got back to normal, is now escalating. And you will see that at about the same time, the Freelite chain ratio is also going up. When we get to over here, this lady became SBE positive. So clearly she was undergoing a further relapse. Okay, let's move on to the next part of this story then, the summary as reported in 2 commentaries that are published alongside this particular paper, are that monoclonal proteins that migrate as broadbands, as this lady's did, can be difficult to distinguish. So I mentioned earlier IgAs which migrate in the same region as transferrin. In this particular case, it was just she had a broadband that was a bit fuzzy and difficult to distinguish. And these doctors suggested that the quantitative assessment of the immunoglobulin Hevylite chain pairs was useful because it provided some additional information on clonal synthesis. And that was backed up by the commentary from James Fay at Stanford University, who suggested that in cases such as this, we now have an alternative, something additional in our toolbox to try and establish what is happening in these cases. Now, recently there was this nice publication by Professor Kraj, who we'll be seeing on Wednesday, I believe, yes, where this group here in Poland has evaluated Hevylite and published their initial findings in Acta Hematologica Polonica, and that's something we will be looking to extend and discuss this phenomenon of Hevylite chain pair suppression with this particular group of individuals. Perhaps a good question to address today is, since you've all been using Freelite chain testing for a while, is, well, why should I use Freelite chain and Hevylite chain testing in my multiple myeloma patients? And I would like to offer you this particular observation to try and illustrate that. The serum-free light chains and intact immunoglobulins are themselves independent tumour markers. And here is the evidence that supports that. This is a group of 164 immunoglobulin G kappa multiple myelomas from Professor Hervé Loiseau's French myeloma group, specifically those in the IFM trial 2005-01. And what we've plotted here are their Hevylite chain values for IgG kappa versus their kappa serum free light chain ratio. So Hevylite, free light. And as you can see by the scatter across this graph, there is no correlation. If you have a low value for Hevylite, you can either have a low value for free light or a very high value. The two are different. They are measuring different things. And as this paper by Aleph et al. Showed in Hematologica in 2007, they may themselves be being produced by different plasma cell clones. So if we look here at an IgG kappa multiple myeloma, here are the IgG kappas shown in blue. We have quite a few cells showing that, alongside those which have been stained for kappa-free light chain. And see, they're totally different cells that are producing these. So, in summary, Freelite and Hevylite are giving you different information, and to monitor a plasma cell tumour clones, you will need to use both, most likely. And here's an example of where that has come to pass in a true patient example. This is data from Heinz Ludwig from Austria, presented at ASH in December as a poster just a month or so ago. And this is an individual where they've done exactly that. They've measured Hevylite in red here and free light chain kappa shown here in blue. And let me just talk you through this particular slide. This patient had initial chemotherapy here on the left-hand side, and they have monitored the free light chain ratio shown here on the right-hand y-axis, and the free light chain level plummets well into the normal range very quickly and then stays like that throughout the rest of this patient's treatment. And we're looking at over 2-3 years here. However, look what the Hevylite chain ratio was doing. It started off at this particular level, and here is the normal range, and it started to come down, but that took a lot longer than what was happening with the free light chain test. So this one is responding better to therapy than this one. And it does eventually come into the normal range for the Hevylite ratio, but it doesn't stay there for very long. Unlike the free light chain level, which is within normal range and stable, this one starts to creep up again after about a year and a half, and is now oscillating to the level that this individual was started on another line of chemotherapy. They had an initial response to it, but it wasn't sustained. And they had to instigate further cycles of therapy, after which they did start to respond, and out to the level that was reported in this particular trial. You can see that here, this patient hasn't actually responded and gone back into remission as far as the Hevylite chain is concerned. If you were just measuring by free light chain, you'd have missed that. There's a clear difference in terms of what these particular markers are looking at, and a indication certainly from people at the Mayo Clinic amongst others is that we now believe that monoclonal gammopathy as a name may be inaccurate. Up until now we have thought the disease is somewhat static with just one clone being operational in these individuals. What we're now getting an indication of is that there are different clones that are operating at different times. We already know with the phenomenon of light chain escape that chemotherapy may get rid of a clone that is susceptible to the drug, but that another chemo-resistant clone may then come to the fore. It looks like this is what is also happening when we examine these individuals using the Hevylite chain test. So, where does this fit into your routine practice was the question I posed to you earlier. And alongside using it for monitoring, we have some early prognostic data. So if I were to give you 2 words, I'd say Hevylite prognosticates. That may be of value to you in your multiple myeloma patients. This is some initial, very preliminary data, again, published by the French group at ASH last December, where they have, in a smallish cohort, seen that there is a negative correlation between the involved and the uninvolved IgG Hevylite. So you see when the value for the involved chain is high, the value for the uninvolved chain is low. And that is true, be it kappa or lambda. So the take-home message from all of that is, if you have an extreme Hevylite ratio, either very low or very high, you are going to probably do worse than if your value is sitting somewhere within the middle ground. Let me illustrate that by means of this Kaplan-Meier survival curve, again by Heinz Ludwig's group and published at ASH last year, where they've looked at baseline Hevylite chain ratios at initial diagnosis for both IgG and IgA multiple myeloma. They have a large cohort of 310 individuals, and let's look at the difference in these individuals according to whether your Hevylite ratio sits within the normal range. Here it is, the green line. And there is your survival. If you then look at the 2 extremes, so on that previous diagram, either very low or very high, you then fall onto this red line, which you can see the survival is quite dramatically reduced with a p-value of 0.01. You don't just have to stop there. You can now incorporate not just your Freelite chain ratio that we've just been discussing, but what about you're also measuring with Freelite chain ratio and you're looking to see whether that's abnormal as well. What happens if you introduce a tiered risk stratification model? This graph looks at 5-year survival rates for individuals who have neither of these 2 risk factors. So you sit in the normal range for the Hevylite chain ratio and the normal range for Freelite chain ratio, and you sit here with quite a good survival. If you have either this one or this one, your risk factor then sits you on this particular line shown here. And if you are unfortunate enough to be extreme for both of them, you'll see that your survival is quite dramatically affected, again with a p-value of 0.01. So in 2 words again, Hevylite prognosticates. Let's summarise all of those points for Hevylite in one slide then. Here are the key points. It's a simple, fast, automated test, much as you have experienced already with Freelite. That's useful. You haven't got to stand by the machine and wait for it to produce the results. It will give you an automatic printout. It does give you the ability to have clear identification, quantitation and typing of M protein. And the ratio, the Hevylite chain ratio, I hope I have shown you, is a sensitive measure of disease, specifically residual disease, that you may not otherwise have been able to identify. And for the first time, you can take into account both the monoclonal and the underlying polyclonal level, so the involved immunoglobulin and the uninvolved immunoglobulin, as I showed you by the green circles representing each chain. Early data also indicates that the Hevylite chain is able to provide prognostic information. So we have a quick test which quantifies, is useful in monitoring and provides some prognostic information. So my question to all of you here is, would you be interested in looking at a clinical study involving these markers? Could it have a role to play in some of your hard-to-monitor patients, such as the IgA individual we looked at earlier? I gave this talk a few weeks ago at Derby Royal Infirmary to their laboratory and their clinicians, and they that morning had a difficult IgA and a difficult IgM to characterise by SPE. And so this is an area where they thought this might be a good extra tool for us to look at. We have some monitoring protocols which we are looking at specifically at the moment for IgA and IgG, and we are happy to discuss that with you all. And prognostic benefit, I think that's an area that's going to be very topical over the next few years. We will see what further data there will be at ASH 2012. I can recommend these two areas for you to get further information on all of the subjects that I've covered this afternoon, specifically keeping up to date with guidelines for the use of the serum free light chain assays. Guidelines for workup have changed quite a lot in recent months, and in particular I would like to draw your attention, if any of you do clinical trials, to this, a consensus opinion by Dimopoulos and colleagues from the International Myeloma Working Group, published in Blood in 2011. That was in June. And secondly, for those of you who are interested in Hevylite, there is a chapter, a whole of chapter 32, which looks at Hevylite chain analysis, and this is all on Wikilite, which is our online version of our serum free light chain textbook. So with that, I would like to ask you if you have any questions, either for me now or in the future. You're very welcome to contact me at my email address, which is alison.levoguer@bindingsite.co.uk. And I would urge you, for both Freelite and Hevylite, to keep up to date, if you have time, at wikilite.com. So thank you very much for your attention.
About Wikilite comments. It's a binding site, it's a connection with binding site?
Yes, it's an initiative which is, do you have a copy of the textbook? The Serum Free Light Chain textbook, okay.
Yes, I have.
All right, so that was recently published in its 6th edition.
Okay.
But all of that content is now online as an educational resource at that particular web address, wikilite.com. Its asset, as with all things to do with the internet, is that it's being updated regularly. So my colleague Josie Evans back at HQ updates this on a monthly basis. So whereas the book is published and then we have to wait until we produce the next edition, this is where we put the latest information. So as and when these new publications arise, the first place you will find them mentioned is on wikilite.com.
Mm-hmm. I have also a question about your recommendation and recommendation of International Myeloma Working Group in new diagnosed myeloma patients regarding Freelite chain. I mean, we have patients, it's induction, of course, autologous transplantation, and later is maintenance therapy. It's, how often it's recommended to do Freelite chain assay? Okay,
there is no strict guideline on you should do it every 6 weeks or what have you. We say, and what the guidelines interpret it as, is when you are seeing these people routinely for monitoring, please consider utilizing this assay. And that is their recommendation. I haven't seen reported anywhere where somebody says that should be every 2 months or every 6 weeks. Okay. I've not seen that information. No.
Have a question?
I have, thank you for your excellent lecture.
Thank you. It's a pleasure.
Working in laboratory for many years, I see several advantages of that Hevylite chain assays.
Yes.
Because what took my attention, that is some kind of absolutely independent test.
Yes.
I have in my mind case reports that there was monoclonal gammopathy seen by electrophoresis, but Freelite change ratio was in normal range. Now I understand it because it's not in every case when you see monoclonal band in electrophoresis, the kappa to lambda ratio will be abnormal. That's additional tool.
Yes.
You show us some electrophoretic separation of IgA in beta region. I've also experienced alpha 2 region, but when we see in our lab beta region very high, let's say 30% or more, we always consider it may be monoclonal gammopathy, and I used to say it will be probably AGA, but it is not the true because from time to time it's IgG.
Yes. Yes.
Not so uncommon. So not only the high beta region is not necessarily IgA.
Sure.
It's also IgG, and we are asked to quantitate monoclonal band on the basis on electrophoresis. And Dr. Jurczyszyn from time to time obtains result. It's difficult to quantitate from that particular patient because of beta region or because high polyclonal background, and we have no tool to monitor that monoclonal gammopathy quantitatively.
Yes.
Now we have another
instrument to look at it. Yes.
Independent instrument to just to monitor that patients. When one patient has that monoclonal gammopathy in beta region, it will be difficult to monitor it during all course of his therapy. So
definitely,
it's not, only once it was not possible this time.
Of course, of course. Because even at diagnosis it's difficult, then you'll treat and it's going to get even smaller. And where does your band...
Next time will be
exactly. However, now, in both of the cases you mentioned, now you have this alternative where you can get a quantitation and a ratio to see where you sit in terms of monoclonality.
Alternative to quantitate that patient, including electrophoresis and perhaps kappa to lambda ratio, because it's possible that in that
doing
patient,
something different.
Kappa lambda ratio will be
I completely agree. Yes, I'm also interested in the case you mentioned where you say not just transferrin, but where you've seen a case where it's actually been IgG. Because you have pairs for G, A and M, theoretically you could take that individual, if you still have serum less, do Hevylite G, A and M across that particular individual and see exactly what those individual classes are doing. That may be interesting as a case example.
And monoclonal gammopathies in beta region or even alpha 2 are not very uncommon, but they recognize much later because they know that monoclonal church-like spike in the gamma region, which we used to.
I think that's a very interesting point you make. A lot of people are used to see a characteristic very large M spike in the gamma region, but for these more subtle alterations, as you say, they are difficult to spot and difficult to get a quantitation on. And we're just saying that you have something alternative here, maybe to give you a little bit more index of suspicion that something is wrong.
Not always very high. So
no, true. That's a very good point. And as you raised, certainly when you have a high polyclonal background, that does make life difficult. And if you have a low monoclonal, yes, I agree. Thank you.
I have a question about this acute kidney injury. Also, it was ratio more than 500.
Okay, so for the first two I showed you, it was the clonal free light chain level, so the concentration 500 milligrams per litre. So above, consider carcinophropathy. Below, not necessarily carcinophropathy, but do a renal biopsy to exclude another cause, something else locally happening in the kidney, which may not be free light chain mediated, for example. And separate to that, if the kappa to lambda ratio is abnormal, you're saying that you do not think there is monoclonal pathology. And that was published in 2010, current opinion in nephrology and hypertension.
And also, do you know any paper about correlation between Hevylite, Freelite, and monitoring minimal residual disease and according to bone marrow aspiration in I forgot the name of this. Not Freelite. It's
Immunofixation?
No, immunofixation. It's a cell separator on,
flow cytometry?
Flow cytometry, yes.
Okay, yes, there has been one study which has looked at Hevylite, Freelite, and flow cytometry, and it was an abstract at last year's IMW in Paris by a French group. Okay. And they have been looking to see how the three studies correlate. There are some differences. A lot of the problem we face is because we would like to do that in our monitoring protocol with people, and that is that there aren't too many bone marrow biopsies done to do these follow-ups throughout the course of monitoring. But that group did look at that initially, and they said they thought that the heavy light chain ratio was giving good information. The IFE was sometimes a little bit off. That was, of course, because of IgG, and they think the IgG metabolism was affecting that, meaning that the IgG IFE was hanging around for longer because the half-life was extended, whereas in the other two cases, the other two classes, it wasn't. Flow cytometry, yes, it looks to be a powerful technique, and it does exist in the consensus guidelines, this new phenomenon that's been introduced of immunophenotypic response. The difficulty is we don't have many centres, many normal centres performing that kind of test, only in research establishments at the moment.
The guest here, Professor Zonneveld, is very familiar with this technique, but in my view is your technique is much better because it's not so much traumatic for
it's
patients.
Not so invasive, yes.
Absolutely.
Yes.
And patients don't like bone marrow
No.
aspiration. I know this because I'm doing this every day, and I think it's quite modern, and also it would be interesting to compare and to do a paper with monitoring according to PET scan.
Yes.
Do you have
yes.
data?
No, there is no data.
It could be interesting.
It could be very interesting. It's an area that hasn't been looked at to date, the whole area of scanning and imaging. I can tell you that our R&D director was 2 weeks ago in Italy discussing exactly this.
Yeah,
so it's a topical area.
Yes,
perhaps that is something that we could look at in terms of monitoring here. But I think we need to start with the basics, which is to get used to the test, to see what it can offer you and your patients and what is different from measuring free light, and then consider it in the whole arena of scanning, definitely.
It could be interesting. We have cooperation with Center of Oncology in Gliwice. They have a program, they do free 4 cycle of CTD protocol as induction. Later they are doing PET scan, and they doing conditioning, and they do total marrow irradiation.
Yes.
And later another PET scan. Yes. And later chemotherapy 200 milligram per meter square melphalan. Later another PET scan and thalidomide maintenance. It could be interesting to do also
this alongside. Yes.
It would be possible to do this in Gliwice, I think, with Professor Gebel. He will be happy to cooperate with your tests.
I mean, it would be interesting because if that's an add-on test in what is probably sounds like a clinical trial, is that right?
No, it sounds something like a single center trial.
Yes.
Exactly like this, because only in this center it's possible to do total marrow irradiation.
Yes.
And it's not possible to other hematology clinic in Warsaw, in Gliwice, or in Wrocław. Only Gliwice has it, and this is some sort of original idea.
That is novel. Yes. Of all the studies that I know we have ongoing looking at various countries in Europe and Asia, there isn't one currently looking at scanning.
I also start to cooperate with them, and I send some patients to this place. Yes.
It's a novel aspect.
Yeah.
Yes. But your point is well made. Anything that is with any hope removing the patients from what is already a quite intensive period of treatment with invasive diagnostic and assessment tests, anything that reduces that, if it's proven to be effective, could potentially be a good thing. Yes.